So welcome for another episode of the School of Airway. This is part 2. I'm going to talk about pre-oxygenating the patient. The old standby has always been the BVM, as you see here. Patient with a drowning or stiff lungs and possibly ARDS, you'd probably press this to allow less leak. And I put a P-valve in case you needed to facilitate recruitment of more alveoli. Now, most people will believe that you can bag up any patient, any pediatric patient. If you can't bag them up, you did something wrong. So I'll make myself comfortable. Okay. Get a face appropriate, size appropriate BVM. The face of the patient usually is not so large. You can actually tilt the head back and connect your BVM and watch the chest rise. If the child were morbidly obese, it would be harder to see if there was chest rise, but this child is not morbidly obese. It's size appropriate. All right. Now, how do I save this child? All right. So most people will not know the weight of their child unless they really actually go to their prenatal care. So I would size up the patient and try to figure out how am I going to pre-oxygenate this patient. So if the child is apneic, I'll use a infant BVM and bag them up. All right. Children are like small little animals. Don't get offended, people. Bag them up like at least 30 a minute, so every 2 seconds. And please don't squeeze the whole bag. The child weighs like 4 cc's. No, weighs like, what, 5 kilos? And it's 6 cc's per kilo. Maybe that's 24. You probably barely need to bag up this patient. You may even need a smaller bag, because the reservoir on this is likely at least 400, 450, or 500 cc's. You don't need to do the maximum bag. Right? You don't want to blow out the lungs. You want to minimize injury. You want to see chest rise and recoil back. Okay. So what else can I do? All right. If the patient was spontaneously breathing, not too lethargic, high flow oxygen. All right. If the kid was wheezing and you auscultated some type of adventitious breaths, this is probably sized up too much, probably too large for this child. If I use my stethoscope and I heard wheezing or rhonchi, I would consider either high flow nasal cannula, which I don't have here, for pre-oxygenation to prevent intubation, or give a treatment through this port, high flow oxygen. All right. Now, if that doesn't work, some Broslo-Lewin tapes come with a part that talks about what devices I would use for intubation. Intubation is an act and a procedure. It is not and will not replace oxygenation, rescue oxygenation. If you truly need to oxygenate the patient, and this kid always winds up in the area of pink and red. All right, more in the pink area. All right, and this device does include BVM, oxygenation mask, laryngoscopes. Does not talk about LMAs. All right, this is a little outdated. I'm going to tell you, for a child, if you're going to use a size 1 laryngoscope, most likely wind up being a size 1 LMA-like device. Now, this device here needs a cuff, and this one doesn't. This is an eye gel. Okay? So if I'm going to start oxygenating someone, I'm going to try to make sure I have a syringe somewhere. Okay? I'll put lube in the back of this baby LMA. This happens to be designed by the company of LMA. I'm using Purell because it's easy to use on mannequins. All right. I'll do a little chin thrust, the chin jaw pull. Try to distract the jaw and the tongue a little bit, and slide this posteriorly as far as you can. Don't say quickly shove, quickly place. All right. Then I would feel the cuff. I see that the inherent confined space of the distal airway and the proximal esophagus is causing a compression on the lumen of the LMA itself and causing me to realize I already have enough air. I shouldn't add too much air. Just enough to cause a seal. And now I can bag. I'm going to tell you the seal of an LMA is not as good as the seal of certain other devices. And maybe on this mannequin it doesn't help. Maybe adding more air would help. Perhaps. Minimal chest rise. Maybe it's too much of a leak. Maybe just this mannequin is not compatible to this device. If you really wanted to prove that there was ventilation going on along with rescue oxygenation, you would use an end-tidal CO2. As long as the child has a pulse and a